We, Department of Anesthesia, Rajagiri Hospital, proudly welcome an astute academician, a true leader, mentor and teacher to many, and an extremely religious human being, Dr. J Balavenkatasubramanian, to deliver the inaugural Rajagiri Novum Oration. So let's listen from the Master, Dr. J Balavenkat.
Let me begin this prestigious Novum Oration by seeking the blessings of Almighty God to shower His grace on each one of us, to choose the right path in our life, both personally and professionally, so that we would enrich the people around us, both at home and in the profession, and make sure that every passing human being who comes in contact with us gets the best from us, and make sure that every person, every patient whom we treat gets the best possible care known to humankind. And conclaves like this gives us the power to learn more new things and implement in our patients, and this gives us the power to prevent a death. Knowledge is power, and it's so important that we imbibe every small bit which happens in this universe to our benefit and to the benefit of the patient who comes to get treated by us. Respected Father Johnson Valapalli, the CEO and the Executive Director of this institution, Father Joy, Father Alex, Major General MNG Nair, the Medical Director, the graceful Head of the Department of Anesthesia of Rajagiri Hospital, Annie Madam, the vibrant brigades of Rajagiri Hospital, whom I've been in touch, Dr. Jesto Kurian and Sachin George, and the entire Department of Anesthesia of Rajagiri Hospital. Padma Shri Rajagopal sir, who just left because he was unwell. My teachers. I have great pleasure in seeing Madam Rebecca Jacob after a long time. My own teacher, Dr. Nirja Bharadwaj, and Dr. Y.K. Batra sir is going to join. Senior members of the profession, and all the friends who have come here from far and wide. Greetings to you. I deem it a great honor and privilege to deliver the first Novum Oration. The minute you see Rajagiri Hospital, I'm not sure what strikes your mind, but what struck my mind is when a loving mother wants to embrace his kid, what would she do? She would open up the arms. And you see, Rajagiri Hospital has opened up its arm, and I think it is very symbolical to embrace every patient who is coming in with love and affection and make sure they go back home with complete cure. This is what occurred to me when I saw the hospital, way it's constructed, the architectural marvel of this institution. The little meaning of Rajagiri, I went through the net, and it said that this is the hill of the king, where the king refers to Christ the King. So I think you are blessed by the Almighty God to serve the society. I was so impressed to see, though the hospital has come into being only in the last few years, they've already made a huge mark in bagging several accolades given by several organizations, and it only clearly shows the commitment that is shown by both the management and the people who are working here in unison to get the best to this institution. I feel very happy that the Department of Anesthesia is led by an excellent leader who has promoted and also helped in sharing of knowledge in this region and also who is the current president of the Indian Society of Anesthesiologists of Cochin City branch. And I specifically chose these two people because they've been working with us for several academic events across the country, and they are a source of great energy and vibration and passion in promoting and knowledge sharing in anesthesia. I bring to you greetings from my alma mater of work, the Ganga Hospital and Medical Center in Coimbatore. This is a 500-bedded tertiary care referral center for trauma, orthopedics, joint replacements, reconstructive surgeries. We have 20 operating theatres, and roughly we operate 100 surgeries every day. And the Department of Anesthesia has got 64 anesthesiologists with the capability to train postgraduates, 8 per year, and also the fellowships of regional anesthesia through the University of Madras, the MGR Medical University, the postdoctoral fellowship, and also through the World Federation to train fellows from across the globe. When a person grows, he cannot take away all the credit that comes to him to himself. For example, if you just look back, when each one of us were born, do you think we knew anything? Nothing. When we were a newborn, we had nothing with us. So as we grew, like building a new house, every brick that is put in to make a home, like that, every brick that has been put inside you by several people for you to accomplish and achieve what you achieve in life. So at the junctures where you get an accolade and award, you need to rededicate it to all those who gave it to you, but for whom you will be nothing. So with immense gratitude, I thank the directors and the managing director of my institution where I work for the past 23 years for giving us the right path and the ethical way to do our clinical work. My team, with whom we work day in and day out, who give us the courage and strength to prosper professionally. To my teachers at BJ Medical College, Pune, and later PGI Chandigarh, who taught us the basics of anesthesia. To my parents-in-laws, and my family for giving me the strength and the power and the energy to push myself forward professionally. Because of all their contribution, that each one of us here as a doctor could prosper the way we are. And I think at every juncture, on every day, we need to think about them for what they have done to us. This slide I would wanted to present in every meeting I go until the last anesthetist in this country has seen this slide. The hand that is big, and there is a small hand holding the thumb. And for me, and I think for all of us, if you introspect, the big hand is the hand of the anesthesiologist. And the small hand is all the other specialties, medical specialties known to mankind, who hold the hand of an anesthetist to move forward. I'm sure you agree with me. Suppose if you take away the entire anesthesia fraternity from this world, do you think any other branch in this world can prosper? Definitely no. Can any surgery be done? Any kind of pain relief can be done? So if you take off the big hand, all the other specialties, be it ENT or ophthalmology, or for that matter, even medical specialties like psychiatry, oncology, you just name it, they depend on you to prosper. And but for you, they will never prosper. And we need to understand the power that an anesthesiologist has inside him. So I think we should call ourselves as the mother of modern medicine. I'm sure you completely agree with me. And even if not, you need to introspect today, and you need to make sure that this gets into your mind to feel extremely positive. If you all introspect, I think we again are the most sacred branch known to mankind. The most powerful entity that we all know is God, because He gives life. And the next powerful person next to God is those who prevent death, which is equal to giving a life. In any institution, when a code blue is announced, when there is a cardiac arrest happening, who is being called? An anesthesiologist is being called, not the cardiologist or a pulmonologist or a hepatologist or a physician. So at the verge of death, the only person who could change the fate of the patient, whether he is going to live or not in any corner of the world, is the presence or absence of an anesthesiologist. Do you all agree with me or not? How many of you agree with me? Please raise your hands. Oh, that's really nice. So, preventing death is equal to giving life, and I think we are truly the most sacred branch in the whole world. Having said this, when you declare yourself as a very sacred branch, comes with it the responsibility to become extremely knowledgeable, that every passing day each one of us gain immense knowledge, so that we employ the knowledge that we gained on every patient that comes in and give the best to the patient. As I said, we have the power to prevent a death. So we are truly a sacred branch. And hence, I think all of us agree, next to God is the angel, and we are all truly the angels of God. And is it true that we know all our potential? Is it true that we feel that we are like angels? I think there has to be a paradigm shift in our thought process. And for that, as an anesthesiologist, now we need to reinvent ourselves, and we should have a complete belief in ourselves, in the power that we have, and we should prove to the world that we are a power to reckon in a hospital. And if we have to get all the accolades and we have to be a power to reckon, then the first thing that we need to do is, because we are the people who are going to prevent the death, we have to inculcate into us some strong discipline, unlike the other human beings around, and it goes into every small facet of our life, because you are an angel. And what are they? Some of the important steps based on science and evidence of the life of an anesthesiologist. It clearly says an anesthesiologist who is to perform the most complex of procedures the next day needs to sleep a minimum of 7 hours the previous night to be in a position to execute the minutest of the procedures that he is going to do with ease, and also to take the decisions which could make a difference between life and death. So as angels, I think it is very, very important that we discipline ourselves for the future. And one of the things which is said, that who makes the right decision, these are several studies which indicates that an anesthesiologist needs to have a clear 7-hour sleep to make sure that he doesn't commit major errors, whether it's medication errors or whether it's a wrong decision that is done on our patients during the intraoperative and postoperative period. And hence, it is very important that you may think these are trivial things, but if you go into the books of several studies which are done to show the most promising and successful anesthesiologists, these are the things which stand apart. Early to bed, early to rise, and it seems the first 1 hour of the anesthesiologist's life on a day is very crucial. The first 1 hour, the anesthesiologist who wants to be very progressive has to spend on something extremely positive. Both physical and mental energy needs to be obtained during the first 1 hour, and a clear strategic planning for the day and for the future, and a little bit of education every morning for the first 15 minutes. So the first 1 hour, we need to inculcate few things: a good physical exercise for 15 minutes or yoga, divine music and positive books to enrich the day, so that you will become such a powerful being inside the hospital, and all the moves that you take will work out very positive. The next thing which is expected of an anesthesiologist to provide the least of errors is to be early to work. If the case is at 7 o'clock in the morning, the best of the results in that particular case will happen if you reach the operating room 15 minutes before, a minimum of 15 minutes before the surgery starts. Majority of the errors that has been found out is when the case was supposed to be at 7 o'clock and the anesthesiologist reaches there at 7:05, when all the other people are inside and he comes in a rush to start the case. Majority of the errors have happened here, including medications error, inability to start an intravenous line, inability to intubate, inability to gauge the comorbid conditions. All this has happened, and this has led to increased morbidity and mortality. And hence, one single most important thing that would be expected from the angels is to go 15 minutes earlier to make sure that we don't commit a mistake and take away the life of a person. And what is that we need to keep a litmus test for ourselves, and that is, we need to exceed our own expectations all the time. And how we do that? By acquiring new skills. And it's very important. May I ask a question? How many of you here use the new tool which has become the fanciest thing in the anesthesia profession, the ultrasound? Please raise your hands. Oh, I am very, very happy to see several hands go up. I am truly happy, Dr. Annie. So many hands went up, because I think 10 years from now, all the anesthesia books will be rewritten, because by the time the India will be a developed country, no female infanticide, no PCP&DT Act, and everybody will have an ultrasound instead of the stethoscope inside the pocket. And in the pre-anesthetic clinic, you will see an anesthesiologist taking the history. After the history, you will see that he will put the ultrasound probe on the airway to see where is the glottis, where is the epiglottis, what is the subglottic area. He will decide which endotracheal tube to put. Then he'll come down, scan the heart and see if there is a murmur, if there is a pulmonary hypertension. Then go down and put it in the stomach to see, like if it's an emergency surgery, to see the volume inside, the gastric volume. So it's not the number of hours of starvation. I think it is just what you see, you believe. And I'm sure this is going to completely change the way we practice anesthesia. Exactly in 10 years from now, we will go into a new phase, a new era of anesthesia practice. And that's because of the new skill that has come inside, the skill set. And it's very crucial and important that all of us should embark into the ability to get into these new skills. And that's why I think innumerable workshops are happening, and I think we should become a part of this. So the world will be divided into anesthetists. It's like before Christ and after death. Those anesthetists who know ultrasound and those who do not know ultrasound. So there is going to be two divisions. And I would wanted everyone here to be a part of this new skill set, because it means a lot. Next is knowledge. That's why WIN Conclave. I think conclaves like this are meant to enhance our knowledge, because as a busy practitioner, when you get into clinical work, you hardly get time to browse in. So I think meetings like this in 1.5 days gives us so much of enrichment. Number 3, very important. This is what majority of the books say about the most successful people who climb up the ladder, or those with tremendous integrity and honesty to the profession. And the 4th one is, irrespective of your growth and your stature, you need to be humble, So humility is the fourth one. So if we have a combination of this, the success is going to be yours because you will exceed your expectations. This is something which again I would wanted to share with everybody. The most successful people on the earth, immaterial of what profession they're doing, if you ask them, why is that they are better than the rest? For example, the peak performers, whether it's Vishwanath Anand or the Mahendra Singh Dhoni, you know why they are more successful and why they are very different. It is because if the match is to be played tomorrow, today evening, Mahendra Singh Dhoni virtually bats to the every ball that is bowled by his opponent. Mentally he plays it, whether it's a bouncer, whether it's a googly. And similarly, Vishwanath Anand, before he goes to the match the next day, he virtually, literally, every step, every coin moved, he plays the game mentally the previous evening. So when he goes to the match, he's so positive, full of ideas, and then the defeat becomes an impossible thing. Similarly, each one of us, I'm not sure how many of you do this, how many of you literally do a clinical case the previous evening before doing it the next day? Please raise your hands. So we see only few successful people doing that. And I'm very happy that I could make one point to you. Virtually you need to do your case the previous evening. Once you have done a pre-anesthetic assessment and you literally plan what would be your approach to do this case next day, right from starting an intravenous access, which size you will use, until what tube or what block, where you will do this, adjuvants, everything you play it once the previous evening and go and do the procedure next day. Believe me, it seems that you will do things at your ease and at your best, and you will be branded as an anesthesiologist par excellence. So I think this is something which I think we need to take care. Coming to the point of perioperative care, do you think that anesthesiologists have a huge role to play in the perioperative outcome? The answer seems to be a very, very big yes. May I ask a question? How many of you see your patient, all your patients, in the preoperative period before you take them into the operating room? Please raise your hands. Most of you, excellent. How many of you see this patient in the post-operative period, literally all the patients? Very few hands. So there is a difference. I think we need to move into an era of being a perioperative physician. I would wanted to confess here, since 2002, we weaned off all the physicians from the hospital. So in our hospital, there are only two groups, surgeons and anesthetists. There are no physicians inside. Whether it's constipation or loose stools or electrolyte imbalance, acidosis or hypertension, or everything is manned by the anesthesiologist. And believe me, this has resulted in excellent outcome. Though we have a panel of super specialists, when we are not able to give solutions to certain problems, we call them, but in general, majority of the perioperative care is done by our anesthesiologist. And what does it mean to us? It means there is a tremendous visibility for anesthesiologists inside the institution, and majority of the committees are manned by the anesthesiologist, whether it's a hospital infection control committee, the pharmacological committee, the resuscitation committee, the code blue committee, you name it, and you see it is led by an anesthesiologist. So it gives tremendous visibility, and the responsibility that you take in this in the growth of the institution directly results in your growth. So I would be very, very happy that each one of you sitting here should strive very hard to go outside the comfort zones, outside the defined zones which we mentally create for ourselves, and come out with extreme success, because we live only once and we should live like a king. Why should you live always like a second fiddle? Why should we always ask for opinions when this is something which it's a paradox? I have spoken in several meetings on this. An anesthesiologist can give anesthesia to a cardiac transplantation, but a small change in ECG, he wants a cardiology opinion. An anesthesiologist gives anesthesia for lung transplantation, but for a small change in PFT, he wants a pulmonary opinion. For a patient who comes with end-stage liver disease, gives anesthesia for liver transplantation, but then when the SGOT, SGPT is raised a bit, you ask for a gastroenterology opinion. It is a true paradox. Do you all agree with me? I think by asking opinions, many people ask me, is it not a medico-legal implication? I don't think so. We have never faced it. I think it is your ability to communicate the issue to the surgical team and the patient attenders, a proper informed consent, and going ahead with the surgery would make a huge difference in the outcome. Because several times you deny the patient the rightful surgery because you listen to the gastroenterologist's opinion to wait to undergo a surgical procedure when he could have actually undergone the surgery. When more than one leader is there, then the ship doesn't go in the right direction. And I would wanted every anesthesiologist to become the leader and the leader of a sinking ship. That is what is said about anesthesiologists. Whenever the ship is about to sink, they take over the leadership. When the ship is floating in good water, in good times, the surgeon becomes the leader. So we are always the leader of the sinking ship. So I would want to urge all of you to become a part of the perioperative phase. Quickly going through some of the most important facets of preoperative care. In an audit which we done in our pre-anesthetic clinic, we asked the patients what were the two dreaded things that they fear when they come for the surgical procedure. First thing they said is, immaterial of their age, they said they feared death due to anesthesia. Number two, what they said was they were very concerned about the pain following the surgery. So the most two important valid points they said in the pre-operative assessment are two things which is completely pertaining to anesthesiology and not surgery. The third thing was only about the surgery and its outcome. So you will now be assured that I think the role that we play in a patient who comes for surgery is equal to or much more for the patient, and hence it becomes very crucial that we see all of our patients preoperatively. Even if it's for few minutes, we see them and we create a plan. Even in developed countries, this is an article from the Australian Incident Monitoring Study, they clearly indicated that inadequate or incorrect preoperative assessment resulted in 11% of morbidity and occasionally mortality. Hence, it's very, very important to go with the pre-anesthetic assessment. This is the place where you will actually build the confidence. And there is another clinical study, a broad study which has been done in multicentric trials. Is the pre-anesthetic evaluation done by an anesthesiologist at this point of time is appropriate? The answer is majority of the pre-anesthetic checkups done are inappropriate because most of the anesthetists ask 5 to 6 leading questions and come to a conclusion. Do you have hypertension? Do you have diabetes? Any comorbids? And the conversation gets very shrunken and very small, and so they're not able to get the wholesome picture of the patient. So this is the study indicates. So it says, careful listening, the most successful strategic planning and outcome depends upon the patient speaking and the physician listening. So careful listening, and you need to account to every symptom, and based on that you build a clear plan of action of the perioperative care. I think this is the first and very important step for success. Many times, if you see, the drug history is not taken appropriately. For example, we had a patient who had a blood pressure of 240 by 140. And this patient was put on 4 drugs. Still the pressures didn't come down, and he came for a tibia fracture. And later, we thought that we waited, did all the investigations to rule out secondary hypertension, and we couldn't get down the pressure. So it was decided to go for a graded epidural. And This patient went for the graded epidural, the surgery was done, the pressures were still high, but the surgery was done after 6 days. And subsequently, after 2 days, a code blue was announced. And you see that this patient went into profound hypotension. And we had to resuscitate the patient and revive him. And the reason was, this patient was on several antipsychotic medications. And the sudden withdrawal of the antipsychotic medication resulted in the pressure shooting up. After 2 days, when the relatives brought all the medicines, they gave it to him, and then the pressures crashed completely. So it clearly indicates that we completely missed taking a history, which resulted in a near miss and a near death. So it becomes crucial that the careful listening and building the plans becomes very important. Another study which saw the patients, the anesthesiologist performing the pre-anesthetic checkup, what were the patients, what they liked the most? They liked an anesthesiologist who's very calm, quiet, absolutely confidence personified, very effective in its communication, taking relatives into confidence, and they convince the patient with their careful words, and they will explain to them that the perioperative period is going to be uneventful. Every patient who walks in needs this comfort, and I think it's very crucial as the anesthesiologist. We need to be a part of a solace to them as they enter into the hospital, because they're really under tremendous stress that they might die during anesthesia. I would wanted all of you kindly conduct an audit in your institution when the patient walks in and find out what is the one which is of great concern to them. Next, I would go in the perioperative outcome. The biggest challenge today is hospital-acquired infection. And a ASIC grade 1 and grade 2 patient now can die not because of the surgery, but because of the secondary infection that they develop when they are inside the hospital, and India is in the red. You all know that there are bugs which are resistant to meropenem, vancomycin now in our institutions. So this is a real threat. And if, as a healthcare provider, as an anesthesiologist, working in the critical areas of the hospital, if we need to implement some changes in your institution where you work to decrease the hospital-acquired infection and the surgical site infection, I would strongly recommend the following points. Number 1 is hand hygiene. May I ask a question? How many of you, before touching the patient and after touching the patient, every time that you do you sanitize your hand with either alcohol or chlorhexidine? Please raise your hands. Very few. So I request, I really mean it. There are only 2 things that has been found out in this world to decrease the hospital-acquired infection. One is hand hygiene, and second thing is nothing below the elbow. 2 simple things to decrease the hospital-acquired infection. And I would wanted you to be an ambassador of preventing hospital-acquired infection by doing this simple procedure of using hand sanitization before and after touching the patient. Then safe injection practices. This is again a study which indicates syringes, especially in several institutions in India, the syringes are shared between patients. Do any institution still do this? For example, the previous patient was given a drug and part of the drug was remaining, and this drug is given to the next coming patient. Happens with opioids and certain drugs. If this practice is there, this has been found out in several institutions, but if it is there, the NABH released a note in which they said that multi-dose vials and sharing the syringes has to be completely abandoned in this country. So we should definitely be not part of a practice of sharing syringes between patients. And we will come to the neuraxial block. So hand hygiene, very, very crucial. And it is very important that, may I ask a question, which I've asked several times, that when you scrub up to do a neuraxial block, how many minutes that do you scrub by clock? How many minutes? How many of you raise your hands for 5 minutes? 4 minutes? 3 minutes? 2 minutes? So it's something which we do on a day-to-day basis, and I could see the conflict of thoughts. So as per the current description, if you need use chlorhexidine in 70% alcohol, you need to scrub for 3 minutes by clock to make yourself sterile. And I would want to again urge all of you to, the nursing homes or hospitals where you go in, if the scrub area does not have a wall clock, may you donate one wall clock. One change that you will make because of the WIN Conclave, a small thing but a very important thing, and you put there and make sure that you scrub for 3 minutes. Believe me, I'm the HICC chairman, and we inculcate this to everybody, including the surgeon and the anesthetist, and we do an audit. You know the compliance level? Last audit was only 48%. Because every 30 seconds looks like 3 minutes to all of us. And if you don't go by clock, you don't scrub for 3 minutes. And may I request all of you to be the champions of the simple technique to prevent a neuraxial infection in our patients who has come with so much faith in you to go back. And we cannot give them a hospital-acquired infection because of a small thing that we failed to do. So one thing that this Lux Novum Oration should do is to make sure that you put a small wall clock in the scrub areas of all your institutions where you go, and make sure that you be the role model in scrubbing for 3 minutes, and do an audit and make sure that all the staff nurses who scrub up for the case and the surgeons even scrub for 3 minutes minimum. And also there are steps for hand washing. If your institution does not has it, please take a picture from Google and please put this in all the wash areas in your institution. Another step that you will take to help your patient. We spoke about safe injection practice, and this is a question. I would wanted all of you to go through the current literature. We have been using povidone iodine for a long time, and now chlorhexidine in 70% alcohol seems to be better than povidone iodine in making the area sterile. I would wanted all of you to go through this and come to a conclusion on what you want to use. In our institution, we have completely switched over to chlorhexidine in 70% alcohol, and in long procedures, it is said after 3 hours, you need to re-scrub the area because the germs come out from the depth and from the sides to make the area very sterile. And yet another place where, as an anesthesiologist, you can improve perioperative outcome is antibiotic prophylaxis. If you're the anesthetist, henceforth, every case that you do, you become the champion of administering antibiotic, the single important step in decreasing the surgical site infection. And you need to administer the drug within 120 minutes of the skin incision. Suppose it's at 8 o'clock, the drug should have been given anywhere from 6 o'clock to 6:30. And you need to be the monitor because surgeons never do this, and it becomes important that you become a component of administering the antibiotic and making sure that you document it. This is yet another thing which I would wanted to share with you. We started this antibiotic shower to all of our patients who come for clean surgeries. Again, chlorhexidine bath the day prior to the surgery and on the day of the surgery. And the bioburden decreases dramatically, and the outcomes are very good and decreases the surgical site infection. So if you are not doing this in your institution, I would strongly recommend you have 100 ml bath bottles which are available with several companies, and you could definitely try, especially high-risk cases like joint replacement surgeries, an antibiotic shower the previous night and the day of surgery. Next, something which is very important, like all of us in the post-operative period, write oxygen administration. So what is the current thinking about oxygen administration? Whether you have done the surgery under general anesthesia or whether you have done in regional anesthesia, it has been found that you give oxygenation minimum for 2 hours. And it has been found that when you do so, the amount of oxygen that is bound to the plasma, the dissolved oxygen is very high. The tissues which were injured gets more oxygen supply, and the wound healing seems to be better, and there is decreased in surgical site infection. So it's a very good take-home message, a simple measure of administering oxygen for 2 hours in the post-operative period for all our surgical patients seems to improve the infection rate. The other thing which is again found to be extremely important is the ambience of the theatre. The temperature that is to be kept inside the theatre has to be between 18 to 24 degrees and the humidity should be between 50 to 55. This again, the small monitor is available. It doesn't cost much and you can definitely donate it if you are a private practitioner to the operating room that you are going, because this makes a huge difference in again the outcome. So the minute you enter the operating room, every day you will notice the humidity and the temperature, and these small things make a huge difference in the outcome, and hence I decided to focus on all the small things. And neuraxial procedures, as I said, it has to be done with complete sterility, and in institutions sometimes you see the senior would ask the junior to wash and the junior scrubs for 3 minutes, wear the apron, tries for a spinal, and when the spinal they don't get, the senior just puts a glove and then goes and does a spinal. And how many of you agree with me? I'm very happy. I think this is a very honest crowd, Dr. Rani. Everybody agrees and admits, and this has definitely to be avoided because of the meningitis. There are a lot of reports of meningoencephalitis even in India following spinal anesthesia. Even we had one case last year. So I would strongly urge that we stick to protocols because we are true role models. Yet another thing which I would wanted to emphasize is many of our postgraduates do not know how to wear a glove, how to wear it sterile. So this is a simple another photograph which all the teaching institutions should put to make sure that the glove is worn appropriately so that the sterility is maintained. So these are all some of the factors as anesthesiologists we can contribute to the outcome, because as I said in ASA grade 1 and grade 2, the single most important reason for morbidity and mortality today is hospital acquired infection, and if we follow these small rules, we have made a huge difference in the outcome. Next is about the immaculate examination of our patient after history taking, and some of the important things which I would wanted to emphasize is the breath holding time. How many of you do in all your patients this breath holding time as a pre-anesthetic checkup? Please raise your hands. Nobody. Very few. So I think this slide I really wanted all of you to take. It came into being long back. Used to be a part of every pre-anesthetic checkup, but it's been completely forgotten. So it's very, very nice. Like if somebody can hold their breath for more than 25 seconds, it shows they have a normal cardiopulmonary reserve. If it's between 15 to 25 seconds, it is limited cardiopulmonary reserve, and if it's less than 15 seconds, it's a poor cardiorespiratory reserve. A very simple test which gives a wealth of information to the anesthesiologist. And the vital capacity is calculated like this. If they have a 25 to 30 second of breath holding, the vital capacity is 3,500 ml, equates to that. And if it's less than 15 seconds, it comes down to 2,000. Those who can't hold it for 5 to 10 seconds, they have a vital capacity of only 1,500 ml. A huge wealth of information that you get by a simple test. And it is also crucial that we need to do all the patients who come in a room air oxygen saturation, because there are several patients who are asymptomatic but who have significant ventilation perfusion mismatch. This is another simple pre-anesthetic test which will give a huge information. Venous access. Thrombophlebitis has become a huge problem now, and I wanted all of you to think about this and also do an audit in your patients. If you have a big vein, and if you think an 18 size needle will go, you should go for 20 size. When you think a 20 size will go, you have to put 22 size. One size lower than what you think is appropriate because of thrombophlebitis. If you put a large bore needle, because many times we teach the postgraduates put a large bore needle, and the large bore needle, when you put it inside the vein, the phlebitis is going to set in within 24 to 48 hours, and we have to go for more lines and venous access. In the pre-anesthetic checkup, in India, especially, I think each one of us have to have a clear-cut idea of preoperative hemoglobin and glycosylated hemoglobin. One in every third Indian is a diabetic, and we need to have a clear protocol in treating these patients. We have two situations. One, the glycosylated hemoglobin will be very high, but the random blood sugar you have taken on that day is low. The other thing is also possible. The sugars are very high, the random, but the glycosylated hemoglobin is low. I would really wanted to each one of the institutions have a protocol in discussion with the surgical unit to decide when you will operate and when you will not operate, because this is a simple factor which is going to go a long way. What we do in our institution is based upon a consensus with the diabetologist. If the glycosylated hemoglobin is high, we look for end organ damage. If there is no end organ damage, we go ahead and do the surgery irrespective of raised glycosylated hemoglobin. And if the patient has got end organ damage, like for example an elevated renal parameter, that means under vascular parameter including retina, then we need to, based upon the necessity for the surgery, if it's an elective procedure, you can wait until you control the diabetic status and do this patient. Next thing is renal parameters. I think I wanted to emphasize this a lot in your pre-anesthetic checkup. Whatever investigate, especially in geriatrics, diabetics and hypertensives, you have to see the creatinine level before you do any administration of drug, because this is the single most important investigation which can push your patients into severe jeopardy. I'll just give an example. There was a patient who came for neck of femur fracture. She was a diabetic hypertensive. Her urea creatinine on arrival was normal, and this patient received, after coming to the hospital, just one single dose of a non-steroidal anti-inflammatory, which pushed her into going in for renal shutdown, elevated parameters, to go on dialysis. So something which I would wanted to emphasize. Next investigation of great relevance to anesthesiologists is albumin. It has emerged as one of the important pre-anesthetic investigation, especially in geriatrics. When the albumin is less than 2 grams, the morbidity and mortality, including wound healing, is going to be very, very high. So this investigation is of great relevance. You do a long case. Serum sodium levels in geriatrics are very important because several of them have hyponatremia, one of the commonest cause of postoperative delirium, which again could be detected by the anesthetist and treated. And in India, also we have patients who, a lot of people consume alcohol, and in the pre-anesthetic checkup, you see that if he is an alcoholic, it's a great idea to start this patient on Thiamine 100 milligram BD the minute you see this patient. And this has gone a long way in decreasing postoperative delirium because of alcohol withdrawal. So I would request all of you to make sure that every next patient you see an alcoholic in pre-anesthetic checkup, start them on oral 100 milligram Thiamine BD until they come for the elective procedure, or if they are for an immediate procedure, continue this at least for 5 days into the postoperative period. So the investigations of great relevance, all of you know, but of this which I would wanted to really stress is the lumbar spine X-ray when you deal with geriatric population. Though we speak more on pediatrics here because of the virtue of the cases that you do and more geriatric population, because degeneration of the spine and scoliosis is very high in Indian population, and you should not be taken by surprise when you wash for a spinal. And with the advent of ultrasound, it's also a great boon now that you do a preoperative scanning to see your spine before you actually perform the procedure. And prehabilitation is something which has come into vogue in several centers in the world. We all know about rehabilitation, but prehabilitation is for all elective procedures, that you put this patient, for example, when they come in, you increase their nutrition and also good chest physiotherapy, and the outcome seems to be better when you start working on them in the preoperative period. So these are few things which are very crucial. In the preoperative medications, we are confronted with some very important dilemmas. The number one is antiplatelets. several of patients who come to us are on 2-drug regime on clopidogrel and aspirin, and current recommendation is you stop clopidogrel but continue aspirin in the perioperative period if the reason for putting this drug was because of a previous cerebrovascular event or a cardiovascular event. So do not stop all the both the antiplatelets at the same time, and aspirin 75 milligram in the perioperative period is recommended. It is not a contraindication for a neuraxial block. Even giving 150 milligram of aspirin is not a contraindication for surgery or neuraxial block. Please continue this in the perioperative period, otherwise there is a very high possibility of a vascular event in the perioperative period. Continue statins because they have been found to be anti-inflammatory. So when we get a patient like this, a patient with crucial rheumatoid arthritis, I just thought I will run through how we do a case to change the outcome for a patient like this. How many of you use preemptive analgesia in your clinical practice? Please raise your hands. It's a great idea to do preemptive analgesia, giving the drug on the day prior to the surgery. All our patients who come for joint replacement surgeries, in the previous evening, we put them on 75 milligram of pregabalin, a non-steroidal anti-inflammatory if it's not contraindicated, 1 gram paracetamol, pantoprazole and alprazolam are definitive components of the pre-operative day, the 1 day prior to the surgery. This preemptive analgesia has been found to produce the central sensitization after the incision is considerably reduced when you use preemptive analgesia, and the postoperative requirements of analgesics are very, very less. So this is something which you should use. So this patient coming for a joint replacement surgery, I could use any of this, but I would wanted to share with you one of the best things that we do in our population who come for geriatrics is combined spinal epidural with very low dose intrathecally to see that the mean arterial pressures are maintained. For example, if you have a patient with 90 years, the intrathecal bupivacaine we give is 0.8 ml. Between 80 to 90, we give 1 to 1.2 ml. And between 70 to 80, we give about 1.2 to 1.4 ml and put an epidural. It gives such stable hemodynamics that you will see the perioperative period is so comfortable and it's never a turbulent one. And at 0 hour, this patient receives an antifibrinolytic, tranexamic acid, the single most important factor which is found to reduce the blood loss. How many of you use tranexamic acid in your clinical practice in your cases? Very nice, actually. Whenever you think of losing 1 unit of blood, if you reserved 1 unit, all the patients who reserved 1 unit should get tranexamic acid 1 gram to start with. And also 1 gram of paracetamol intravenous, again a component of preemptive analgesia. Dexamethasone 8 milligram at 0 hours and 8 milligram after 8 hours. 2 doses has been found to be of great use in a component of multimodal analgesia and also as the drug for postoperative nausea, vomiting. So the antibiotic which we discussed and an antiemetic to prevent postoperative nausea, vomiting, we use ramosetron. So ramosetron and dexamethasone together prevents the postoperative nausea, vomiting. All kinds of blood conservation strategies to be adopted. And another important thing is tourniquet time and the tourniquet pressure. The tourniquet pressure, the current recommendation is 100 millimeters mercury more than the systolic pressure. So if it 140 is the systolic pressure plus 100 millimeter, is 240 sufficient enough? If you keep 450, the patient complains of significant pain in the postoperative period because of the tourniquet, and it is really not required to keep such very high pressures. And positioning that all of you know, and one of the main reasons which we have been found even in Indian scenario is because of improper positioning, and several case reports have come. And intraoperative thermoregulation is another very crucial thing which several of us miss, especially in long surgeries because of the coagulopathy will increase in hypothermia. So it's a great idea to use thermodrapes and also online warming in all our patients. The last concern is pain. And I think how many of you here write the postoperative order for all your patients that you're giving anesthesia? Partly. I think this has to change. From Monday, please take it off from your surgeon. please relieve them of the burden of writing post-operative orders, and you need to take and write the post-operative orders, and for two reasons. One, it can be timed well, it has to be multimodal. Third thing is a regional anesthesia should be a component of your multimodal analgesia. There are several articles to say the outcomes are extremely good in the post-operative period when the multimodal analgesia is given. For the same patient which I showed, we give 1 gram paracetamol 6th hourly for the first 5 days. Non-steroidal anti-inflammatory ketorolac 30 milligram 8th hourly up to a maximum dose of 90 milligram. Pregabalin 75 milligram in the night. And only caution is when you use pregabalin, some of them are highly sedated. You need to withdraw the drug if they are highly sedated, because if they start ambulating, they may fall down. Dexamethasone 2 doses. And when you start using all this, the requirement of opioids comes very low. And we also use extensively the newly available slow release patches of buprenorphine 10 milligram. Excellent addition to post-operative analgesia in all our patients. And every patient gets an ultrasound guided block. This is single most important factor. All the scoliosis surgery we do gets an erector spinae block. All the surgeries we do a bone grafting get a QL block or a transversalis fascia block. You have to see the patient that the VAS scores are less than 3 for the first 48 hours when you incorporated regional anesthesia into your patient. The single most intervention which has completely changed the post-operative phase of your patient, and more so if they are a hypertensive diabetic coronary artery disease, because the single most important cause of post-operative myocardial ischemia in the immediate first 12 hours is acute pain and increased sympathetic activity and reduced sleep. So I would urge all of you that if you incorporate regional blocks, it is going to be excellent for your patient. And now we have gone to periphery, like local infiltration analgesia. All of the joint replacements get actually a subsartorial plexus block. Ultrasound has to be used extensively. And as I said, that in our institution we do on-arrival block. The minute the patient comes in, immaterial of the time of surgery, the block is instituted, whichever part it is, immediately, so that the patient becomes completely pain-free on arrival. If they're not fit for a procedure, we go for catheters. We make the internal milieu better. Until then, they'll have a catheter infusion going on with elastomeric infusion pumps. Before I conclude, I would also wanted to say, I would also wanted all the seniors here to think about professionalism and guidelines. Several times, guidelines are there to guide, but then in a given instances, your professionalism should outsmart the guidelines. One example wanted to give. Yesterday, this case got discharged from the high dependency unit. We did it 4 days ago. This patient fractured neck of femur from a poor socio-economic strata, hypertensive diabetic coronary artery disease with a EF of 45%. Investigations done, ECG done, no angio was done. Patient was shifted into the theatre to see the T down, ST depression happening, but she was also having significant pain. Now we gave the femoral block, made her pain-free, gave a little bit of opioids, sent for the attenders. She was inside the theatre, spoke to them about the cardiac event and spoke to them about the need for an angiogram and possible. So bluntly they said, we don't have a single penny other than this surgery. Whatever happens to the patient, it's fine. We don't have money to get an angiogram or an angioplasty or a CABG. So now you are stuck with a situation where either you postpone the case or you go, she was hemodynamically stable. So we went ahead after getting a written informed consent, but the goal was to maintain the same mean arterial pressure. The pressures were about 140/80, so we wanted to maintain the same pressures in the intraoperative period. Again, this femoral block, combined spinal epidural, very low dose. She was 74 years. We gave 0.8 ml intrathecal, put an epidural infusion, maintained the mean arterial pressure throughout, didn't rush fluids inside, gave blood for blood, monitored the patient for 4 days post-op. Actually, 4 hours later, the TROP-T came positive. But our goal was to maintain the map completely in the perioperative period, use epidural infusion, multimodal analgesia, keep the patient pain-free. Yesterday, after 4 days of surgery, with stable hemodynamics, shifted back to the ward. The point I would wanted to make is many times as clinicians you're confronted with a situation where you're challenged to go against the guidelines, but I think as you grow up the ladder, it becomes crucial to exercise your professionalism and experience in that particular instance and make sure your patient lives. Postponing the case would have been the easiest thing. Cardiology opinion would have been the easiest thing to do, but then you made a difference in the life of the patient who believed in you and came, and you made a difference and made sure that they live. So I think this is a challenge, and I would wanted all of you to think about this, especially those who are in very senior level. Before concluding, a couple of statements. The happiest people don't have the best of everything. They just make the best of everything they have. And I would wanted all of you to use the best of everything you have. And you should become a class apart in your institution and in the place where you work. You should strive hard to make a difference, and everybody around you. This slide I've used several times, but I think there should be a purpose for us to be a professional. There should be a purpose for us having born and living as an anesthesiologist, that every person in your department should praise you as world-class, unique, and very innovative. And this is another slide which I like the most, because as seniors, even if you are one junior, you become the role model for them. You are the true Quran and Bible and Veda for them. Everything that you do, your junior is watching, and he just does the same way that you do. He reads the book but does what he sees in you, and hence it's very important. It's a huge responsibility that each one of us who have got even one junior should be a true role model to them, so that they get the best of practices and make sure every patient who passes by them gets the best perioperative care. And the last but one slide, this is Stephen Covey, a person of tremendous repute. When he died, 33 leaders in the world, the presidents and the prime minister, were his clients, and he said, all the people living in the world are faced with challenges, but few of them are successful and few not. Who are those who are successful? He said, everybody gets the same stimulus, but the response differs. So there is a space. In that space between the stimulus and the response is the power to choose your response. For example, we discussed several points today. So the stimulus has been given, and the way you respond is going to determine the way you're going to live, determine how good you're going to become a professional. So he says, in that response between the stimulus lies your growth and lies your power to grow. And I wish that each one of us here have the power to prevent a death, have the power to recreate life. And we need to take the responsibility that has been adorned on us by God to make sure that we become extremely capable in doing every single act as an anesthesiologist, so that we prevent a possible death. Thank you very much for patient hearing, but if we do all this, each one of us become iconic, and the fraternity would become iconic in what it does, and we'll do tremendous justice to every patient and to our country. And the last statement I would say, if we consider every patient coming to us as our own kith and kin, every pediatric patient that comes to you when you anesthetize, if you consider that it is your own child, and if you impart on them the same perioperative care that you will do for your child, not a single child will die. And that should be our motto, and that should be our will. And I'm sure together we will all raise and make sure anesthesia will be respected in the ages to come, and it will become the mother of modern medicine. Thank you very much for your patient hearing, and I feel delighted to deliver the first Lux Novum Oration, and I hope that, true to its meaning, I was able to impart a small light that would help us to enrich and grow. Thank you.
Thank you, Doctor, for your truly motivating and informative talk.